Left reciprocal. Okay, plus after we finished all the bradyarrhythmias, just we want to go through the treatment. We said that there are many causes of physiological asymptomatic bradycardias we are not going to treat. But if you find that the patient has asymptomatic Mobitz type 2 or asymptomatic third-degree AV block, you need to investigate the patient, and you need to consider treating the patient by pacemaker or not, because if the patient is still asymptomatic right now, he may deteriorate later on. So you need to put him on for investigation. Don't just discharge. Unfortunately, you'll have to refer to us. If the patient is any kind of AV block or SA nodal block, then you will need to treat because he has symptoms. What are the symptoms that will cause the patient to become unstable? Chest pain, shortness of breath, hypotension. So if the cardiac output equals heart rate into stroke volume, so if the heart rate goes down, cardiac output means it's going down also. So less cardiac output to the brain, dizziness, pre-syncope, syncope. Less cardiac output to the periphery, so blood pressure will be less than 90. Less cardiac output to the coronaries itself, chest pain, ischemic chest pain. And because less blood supply to the coronaries, the heart is not getting blood good perfusion, so less cardiac output, filling is more, maybe pulmonary congestion, lung congestion. So these are the signs of instability. If the patient is unstable, you need, number one, to call cardiology. Yeah? And then start your treatment, because when you call cardiology, we will come after a long time. So if you give the treatment, you need to give what medication? Atropine. How much? 0.5 mg. The ampoules that you have here is 0.6. Doesn't make difference. So if it works, fine. The heart rate improves. That's okay. If the heart rate doesn't improve, the patient is still asymptomatic, what you will do?
You can continue
Repeat
to give
another
it.
one. How much?
Till 3, you can give.
Till 3 mg. Still the same. You will not make it 3.5?
No.
Why?
If it hasn't worked so far, I don't think it's going to work.
If it has worked, it can work more.
No, if it hasn't worked so far, then it's not going to work anymore. Maybe the
This
nodes
is
are
not-
blocked.
This is not the reason. That's the maximum dose for what?
Atropine.
Not for the atropine. You can give atropine 5 more.
All the channels are blocked.
Excellent. So all the cholinergic receptors will be blocked. So whatever your dose you increase, you will work on the muscarinic. So the patient just will get dry mouth, will get constipation, will get the side effects only, but he will not benefit from the heart rate. So that's why we stop at 3. If you reach 3, still the patient is symptomatic. What you will do? Okay, you will try the pacing till they get the machine. Dopamine infusion. How much?
Epinephrine. 2 to 10.
2 to 10. Or microgram per kg per minute or per minute على طول?
Per kg per minute for dopamine.
Per kg per minute. Okay, then if it works, it's okay. If it not,
Epi.
and why dopamine, not dobutamine?
Dobutamine needs a higher blood pressure.
Excellent. Because dobutamine, both they work on the same receptors, but the dopa works more on the heart rate. Dobutamine works more on the blood pressure. Okay. So then norepinephrine, epinephrine if the patient is not responding to the dopamine and transcutaneous is not there yet. Once the transcutaneous pacing arrives, you will have to apply the transcutaneous pad. How you will put it? Sedation. Why sedation? Because the patient will feel the twitches in the muscles, yeah? electrical activity will travel through the chest wall to the heart. So patient will be irritated with this electrical activity. You need to give a little sedation. With what?
Midazolam or anything.
Diazepam? Okay. So you go for something else. Yani, because diazepam and the patient is already on block, you will deplete the AV node completely. You completely deplete the block the AV node. So then when you apply the pad, what you have to do, the cursor is adjusted towards monitor and joules, so you go in the other
Pacing.
direction, pacing. Once you go to the pacing, two parameters will appear. One is rate, some machine write frequency. Another parameter is MA, milliamperes. So once you switch into pacing, rate. So usually you want to make the rate 70, 80, and it will show you the milliamperes. Then you start to increase the electrical activity. What will it do? The same. It is the same machine that is connecting from the AC into the machine. It converts the AC into DC from the AC becomes direct current. Then, if you want to defibrillate, you make it on 200 joules, and it will give the whole 200 at one time. No, if you make it at pacing, it will give little electrical activity with frequency. Like if you make it at 60, so every 1 second it will emit few milliamperes. Okay. Then, with this, when the milliamperes show up, then you need to increase the electricity. So it will show you according, there are cursor and there are buttons. If it is cursor, there is usually course adjustment and fine adjustment. So with the course adjustment cursor, you go 5, 10, 15, like this. So when you go 5, still the same, nothing at all. Go to 10, you make it 10, you start seeing spike, okay, with QRS complex, which is discordant with discordant T. So this means that the ventricle captured the pacemaker, the transcutaneous pacemaker, captured the electrical activity. Okay, so this was enough. Then maybe it is more than enough, because you want the least effective and tolerable electrical activity. So you reach 5, 10, you saw the spikes and the capture beat, you start to decrease now with the fine adjustment. 9, still there. 8, still there. 7, still there. 6, disappear. So you make it 7. Okay? So you make it the least effective, tolerable milliamperes. If it is buttons, you will just keep increasing with the button till you find the spike and capture beat, and then you stop. Till we arrive, and then we will, the cardio will put transvene.
We go from that, from the lowest up here, we increase, or we start with 10 and then we
what I like is to increase till you find the spike, because you don't want to waste time. In such situations, the patient who do not respond with the medications, you need faster action. Okay, so time for break. We'll come back after.